Very good morning. A very good morning to everyone from east to west. Today we have a very distinguished speaker, Dr. Patrick Kamath, who is a transplant hepatologist at the Mayo Clinic in Rochester, Minnesota. As you all know, he has played a pivotal role in advancing hepatology, particularly in the management of portal hypertension, ascites, variceal bleeding, and hepatic encephalopathy, and hereditary hemorrhagic telangiectasia. One of his key contributions in his career is his seminal work on the model for end-stage liver disease score, which has transformed liver transplantation by optimizing organ allocation based on objective disease severity rather than waiting time. His research in MELD has significantly influenced clinical decision-making, improving outcomes by prioritizing patients with the greatest need for transplantations. Dr. Kamath has completed his medical training at the Postgraduate Institute of Medical Education and Research and the All India Institute of Medical Sciences in India, followed by advanced fellowships at the Mayo Clinic, College of Medicine. His contributions to hepatology research and education have been well recognized internationally, earning him the International Recognition Award from the European Association for the Study of Liver Disease in 2022 and the Distinguished Educator and Mentor Award from the American Association for the Study of Liver Disease in 2018. He's a member of multiple different professional societies. Dr. Kamath has served as an associate editor for hepatology and clinical gastroenterology and hepatology, and is currently an associate editor for gastroenterology. His extensive work, both in the pre and post liver transplant care, complications of cirrhosis, and vascular disorders, solidifies his standing as a prominent expert in the field. With that introduction, I would like to welcome Dr. Kamath, who's going to talk about risk of infection and cirrhosis. Dr. Kamath, over to you.
Thank you so much, Sanjay. Thank you for inviting me. And for today, I'll be speaking on management of infections in cirrhosis. I have no conflicts. I need to acknowledge my colleagues, Jazz, Bajaj, and Raj, ready for the use of selected slides in this presentation. So let's take a case scenario, and this is something you probably see really very often. This is a real-life patient, 33-year-old female, alcohol-associated hepatitis with cirrhosis, MDF 52, MELD score 36, pulmonary infiltrates, sputum cultures grow Klebsiella pneumonia, progresses to multiple organ failure, and dies 7 days post-admission. So when you see a scenario like this, the questions that arise are, what are the challenges in managing patients with cirrhosis and infection? And why is mortality so high? So in this talk, I'll go over what are the common infections, why do patients get infected, what are the consequences of infection, how do you manage such infections, and then finally some take-home messages. So first, what are the common infections? The bacterial infections in cirrhosis account for about 25% of all deaths in cirrhosis. In hospitalized patients, about 30 to 50% will have infections. Once a patient has cirrhosis, there's a fourfold increase in the risk for nosocomial infections. And to define these infections, nosocomial means any infection that occurs 48 hours after hospitalization. Healthcare associated is hospitalization or inpatient procedure within the previous 6 months. And community acquired is neither nosocomial nor healthcare associated. So I'm going to be using these terms in the talk. So coming back, what are the common bacterial infections? Spontaneous bacterial peritonitis, urinary tract infections, two most common, followed by pneumonia, and then bacteremia. So bacteremia can be a spontaneous bloodstream infection, or it can be following an invasive procedure or placement of a catheter. So spontaneous bacterial peritonitis, urinary tract, pneumonia, three most common infections in cirrhosis. Now, challenge, nosocomial infections in patients with cirrhosis. This is the study, the North American study, multi-centers. In red is a second infection. Blue is the infection at the time of hospitalization, and red is the second infection. And so most second infections occur after 48 hours, and therefore most second infections are nosocomial infections. So the nosocomial infections are respiratory. So remember, they're the most common infections at admission, along with urinary and SPP, but they are also the most common nosocomial infections. Then there is C. difficile and fungal infection. So to summarize, respiratory, C. difficile, and fungal infections are the most common second infections in these patients, almost always nosocomial. Mortality with nosocomial infections is high. So generally, spontaneous bacterial peritonitis, respiratory, and C. diff, 37 to 40% infection rate and mortality. To summarize the common infections in cirrhosis, SPP and urinary tract infections are the most common community-acquired infections. SPP, urinary tract infections, and spontaneous bacteremia are the most common healthcare-associated. UTI and C. difficile are the most common nosocomial infections. And nosocomial infections are associated with a higher mortality, somewhere in the range of 30 to 40% in hospital mortality. Now, infections are rising. So these data were published in 2016. It takes some time to actually get all the data, and this is by my colleague Alina Allen. So you can see infections in patients with cirrhosis who don't have multiple organ failure is under about 10%. But once they're going to multiple organ failure, it's about 70%. So that means most patients with multiple organ failure are going to be infected. And look at the cost of this. Let's just focus on multiple organ failure, most of whom have infections. So the cost is almost 5 times that of congestive heart failure hospitalization, 2.5 times sepsis due to any other reason. Length of hospitalization, these infected patients, 16 days hospitalization. These are national figures from the CDC. Sepsis, half that time. And then finally, look at the mortality, 50%. So infections associated with high mortality, long hospital stay, and extremely expensive. Not only that, over time, we have not gotten that much better in treating these patients. Yes, about 25 years ago, mortality was between 60 and 70%, but it's still upwards of 50%. So that means maybe we're doing slightly better, but it's still a huge problem. Not only that, there is the risk of multi-drug resistance coming up. And so you can see multi-drug resistance throughout the world, how many additional deaths they're going to cause. So it is anticipated by 2050, multi-drug resistance will result in 10 million more deaths, and patients with cirrhosis have multi-drug resistant organisms. So like I said, by 2050, 10 million additional deaths because of antibiotic resistance. And you know, there are really not many antibiotics that are coming out, which are new classes. So patients with cirrhosis who have bacterial infections have a high risk of organ failure and mortality. If they have multiple drug-resistant organisms, and I'll define them in a bit, they've got a poor response to antibiotics, and they have a high risk of mortality. So let's look at this global study, which was headed by Paolo Angeli from Italy. Worldwide, and we're looking only at patients with cirrhosis, 1/3 have multiple drug-resistant bacterial infections. And what does multi-drug resistance mean? They've got resistance to more than 3 classes of antibiotics. Extensive drug infections were 10%. What does extensive drug resistance mean? Only a single class or at the most 2 classes of antibiotics will help in these patients. They're resistant to all others. In the US, multi-drug resistance is 16%, but look at India, multi-drug resistance, 73%, and extensive drug resistance is 33%, meaning that in 1/3 of these infections, only things like carbapenem are going to work, and the cephalosporins that we typically use are not going to work. So now that we know there are common infections, the question is, why do patients with cirrhosis get infected? So there are multiple causes. One is this alteration in the gut barrier, so that the gut barrier becomes more leaky and the immune cells in the lamina propria are less effective. So changes in the microbiome, more bacteria escaping into the circulation because the surveillance here in the lamina propria is not that effective. Then these bacteria go to the liver. Normally, the liver in the reticuloendothelial system and in the circulation should take care of it. But for multiple reasons, these bypass the liver and they get into the systemic circulation. Additionally, patients with cirrhosis have malnutrition, alcohol, may be genetically predisposed. They're on drugs, which we'll talk about later. All these predisposed to cirrhosis-associated immune dysfunction. So bugs from the gut coming into the circulation, not cleared by the liver, and then they get into the systemic circulation. So what is translocation? Transport from the gut into the circulation through the mesenteric lymph nodes and portal vein. As a result of getting into the circulation, there is bacteremia and there are pro-inflammatory cytokines. So we get systemic inflammation in these patients. And this pro-inflammatory response leads to tissue injury and organ failure. And I will go over details of this in the next few slides. So patients get infected because of an interaction between the host and the bacteria. So there are host factors. How bad is the liver disease? How old is the patient? Does the patient have diabetes? What are the medications? What's the nutritional status? All these make patients more prone to injury, to infection. And then there are pathogen factors. How virulent is the bacteria? How big is the bacterial load? What about pathogen-associated molecular patterns? Anyway, the result of this is a pro-inflammatory response resulting from the host pathogen interaction. Once the inflammation starts, it's propagated because leukocytes are activated, complement is activated, and this activation of the coagulation system. This inflammation results in cell necrosis. The cell necrosis propagates inflammation by releasing damage-associated molecular patterns. There is also hypoxemia and ultimately organ failure. So to summarize, this is an immunological problem. At homeostasis, there's a balance between the pro-inflammatory response and the anti-inflammatory response. Initially, there's immune activation, but after many days, there is immune suppression. This results in the risk of second infections, which ultimately lead to death. And this is the reason why nosocomial infections are associated with such high mortality. Now, not only that, there are some agents that we use that make patients more prone to infection. PPIs increase the rate of serious infections. Does not seem to be a problem with H2 receptor antagonists. So we have to balance bleeding risk with the risk of infection. Not only that, PPIs significantly increase the chance of developing C. diff infections. This is worrisome. So this is a paper just 3 months ago in Nature. Rifaximin prophylaxis causes resistance to the last resort antibiotic, daptomycin, which is used for VRE faecium. And so please be extremely careful about using rifaximin. So what do we have to say about PPI and rifaximin and cirrhosis? Both are good drugs. Just be very careful about how you use it. So if you see a patient on a PPI, go over the history again. Make sure they truly need to be on a PPI. If they're not required, consider discontinuing them. Certainly go back. Typically what happens is the patient is prescribed a PPI, and this just keeps being renewed in perpetuity. Your patient with rifaximin, remember, rifaximin use is for patients who have failed lactulose. That's when you can use them. For primary prophylaxis during a variceal bleed, rifaximin does not help during that time. So be very careful about using rifaximin. Use it only in patients in whom you have real difficulty in controlling hepatic encephalopathy. So now we know why patients get infected. What are the consequences of infection? So there's an inflammatory response that leads to a second infection, which worsens the systemic inflammatory response that gives rise to organ failure. And in the absence of liver transplantation, these patients will die. So those are the consequences of infection. Now, an organ fails because it gets less oxygen. Why will an organ get less oxygen? Either there's less blood going to the liver, or to the organ, or that the mitochondria are not functioning adequately. So let's look at blood flow first. In infection, there's release of neutrophil extracellular traps. These are a scaffolding in which platelets get trapped, and therefore you get thrombosis. This thrombosis is propagated because of a decrease in activated protein C. So you get a clot, then the clot is activated. There is endothelial cell dysfunction, which gives rise to vasodilatation. And then somewhere key here is CYP3. CYP3 plays a key role linking inflammation and coagulation. So when CYP3 is activated, we get low activated protein C, a decrease in vascular cadherin, and the tight junctions become loose. We'll come back into this in a bit. On the tissue side, there's release of mitochondrial contents with mitochondrial dysfunction. If the mitochondria are not working well, there's less tissue oxygenation. Going back to the vessels, thrombosis and endothelial dysfunction causes tissue hypoperfusion. Endothelial dysfunction causes a drop in blood pressure, red cells get deformed, all of which results in tissue hypoperfusion. The cell membranes get leaky, so there's loss of barrier function. There's capillary leak and interstitial edema. That again decreases oxygenation. So tissue hypoperfusion, loss of barrier function, and mitochondrial dysfunction give rise to tissue oxygenation defects, which then give rise to organ failure. And the organs that fail in patients with infection and acute and chronic liver failure are the brain, where you get hepatic encephalopathy and cerebral edema. You get acute lung injury. The liver becomes intensely cholestatic and worsening of liver injury. Patients get hypoglycemic. There's adrenal dysfunction, acute kidney injury, worsening of immune suppression, and that propagates the sepsis. So the consequences of infection are high mortality risk, development of nosocomial infection, including fungal infection. You get multi-drug resistant bacterial infections, high risk of readmission within 3 months. I've not shown you that data. Delisting for liver transplantation, again, I've not shown you that data, but these are huge problems in these patients. So the big question here is, how do you manage such patients? So infection management generally, we know these patients started off with liver disease that was compensated, or they were managing in the community. There was some major insult, infection or not infection related, that resulted in inflammation, sterile or infection mediated, which gave rise to hepatic and extrahepatic organ failure. This hepatic and extrahepatic organ failure increased the risk of infection which worsens multiple organ failure. So the treatment here is reverse the cause. Try and treat the insult, try to treat the infection. We don't know about liver support devices right now, but possibly they have a role. And if you can reverse cause and treat the infection, you may go back to where they were at baseline. But if that's not successful, these are patients who are candidates for liver transplantation. So this is how we typically go about evaluation of a patient. When you first see the patient in the hospital, arterial pressure less than 65, hypoxemic, tachycardia or bradycardia, tachypnea, alteration in consciousness, that is a patient you should send to the intensive care unit. And in the intensive care unit, there are several investigations that need to be carried out. I will go over them in detail in following slides. We have to treat the infections very aggressively. We use general measures in these patients. Again, we'll discuss them in detail a little later. If they're hypotensive, despite all this, then we put them on norepinephrine. If despite norepinephrine, they're hypotensive, then you consider steroids. However, the majority of patients don't need to go to the ICU. In these patients, what we do, paracentesis with cell count, culture the blood, ascitic fluid, and urine, chest X-ray, and if they have more than 3 unformed stools, check for C. difficile. Remember, when they're on lactulose, this becomes a little bit of a problem. If the ascitic fluid shows more than 250 neutrophils, you have diagnosed spontaneous bacterial peritonitis. The treatment is cefotaxime 2 grams every 8 hours, albumin 1.5 grams on day 1, and 1 gram per kilogram on day 3. And in 48 hours, you're going to repeat a paracentesis to confirm that the neutrophil count is below 24, has dropped by more than 25%. If they've got pulmonary infiltrates, respiratory symptoms, crepitations, especially if associated with leukocytosis or fever, that is pneumonia. If they've got urinary symptoms and high urinary white cell count or positive urine gram stain or positive urine culture, remember these patients should be symptomatic, especially in women. That is a urinary tract infection. So pneumonia and urinary tract infections, remember they can be nosocomial, so decide, is this community acquired, is it healthcare associated, or is it nosocomial? And the antibiotics depend on which of these it is. The response to antibiotics for pneumonia and urinary tract is clinical and radiological resolution of pneumonia. And patients with urinary tract infections, you don't need to check the urine again. It should be clinical resolution of urinary tract infection. Symptoms have gone away. If there are more than 3 unformed stools, check C. difficile in stool. If you confirm C. difficile infection, vancomycin 125 every 6 hours PO for 10 days. If these are patients in the intensive care unit, you may also consider parenteral metronidazole. If you've got symptom resolution, that is what you want to aim for in C. difficile infection. And finally, if you've got blood cultures which are positive, that's a bloodstream infection. Piperacillin tazobactam, you have to get aggressive here, 4.5 grams every 6 hours. Remember, there are 2 different doses of piperacillin. Community-acquired infections, once they come into the hospital, 3.375 grams every 6 hours. But if they have a bloodstream infection or if they're in the intensive care unit, then the dose is 4.5 grams every 6 hours. And for bloodstream infections, you want symptom resolution, that is no fever, and you want negative blood cultures. Now, all this is if things are going well, but sometimes things don't go well. So if there's no resolution or the condition worsens here, these are the options. You have a family meeting, decision, discuss things, discuss the option of liver transplantation in the future, and maybe the decision is for end-of-life care. On the other hand, at the end of the family meeting, we may decide to escalate treatment, and that's when you consider moving the patient to the intensive care unit. In the intensive care unit, the investigations that will be carried out are a paracentesis, culture blood ascites, urine, chest X-ray, lactate. Lactate can be elevated due to liver disease, but the assumption is until proven otherwise, it's related to infection. We will treat the infection aggressively, broad spectrum antibiotics, which I'll get into. 48 hours in the intensive care unit, 48 hours of antibiotics, they're not doing well, consider antifungal treatment. General measures important. Fluid resuscitation within 3 hours. Therapeutic paracentesis, that helps increase blood flow. Aspiration precautions. DVT prophylaxis, important, and stress ulcer prophylaxis. Remember, talked about PPI versus H2 receptor antagonists, and PPIs seem to be better in this situation. Mean arterial pressure, despite all this, less than 60, some might say 65. This is septic shock. Norepinephrine, despite norepinephrine, continues to be hypotensive. Consider hydrocortisone. So this is the evaluation in the intensive care unit. Now, this is really, really important. So this is a study from Canada looking at mortality in patients with cirrhosis and the timing of effective antibiotics, not just any antibiotic, effective antibiotics. Really, your window is within 3 hours, preferably within the first hour of hitting the ICU, they should be on an effective antibiotic. Our policy at Mayo has been, if there's a patient like this shows up at the ER, then the critical care team will go down to the ER, and really the first shot of antibiotic is in the ER, even before they hit the intensive care unit. Once you go beyond 6 hours, mortality is increasing. And essentially, if you started antibiotics, even if effective after 6 hours, essentially you're going to lose this patient. So start effective antibiotics very early. So what are the recommendations for the antibiotics? HBP, cefotaxime, urinary infections, quinolones, or sulfamethoxazole trimethoprim. Now, each institution has their infectious diseases guidelines, and each institution has the infectious disease police. They're going to police the antibiotics. So my suggestion has always been work with your infectious diseases team and work out a list of antibiotics that you're going to use just so that you don't have to call them every time. For pneumonia, levo, it's an aspiration pneumonia. So if this happens in hospital, it's going to be levo and metronidazole. Spontaneous bacteremia, piperacillin tazobactam, remember the dose, the higher dose, 4.5 grams every 6 hours. Cellulitis, cefazolin, piperacillin tazobactam, vancomycin if there's MRSA. Question here is, what is the role of antibiotic prophylaxis? So here, something again against current dogma. There is new data coming in, so I would recommend that you look at this paper. It's going to come out in the Red Journal. It is from the VA. It's available online, and I have the PMID number here. So they looked at patients who had SPP. Some were put on antibiotic prophylaxis or took antibiotic prophylaxis. The others didn't. When they followed these patients, those who were on antibiotic prophylaxis actually had a higher rate of SPP. And with time, this has increased. Why is that? Because the antibiotic prophylaxis we are giving is for gram-negative bacteria. So this was traditionally, those were the infections. But now the infections are moving more towards gram-positive. So by killing the gram-negative bacteria, we are selecting out gram-positive and actually making patients more prone to infections. So it is anticipated that the future guideline will caution against using antibiotics for SBP prophylaxis. So, some take-home messages here. I've given you just a broad overview. I'm happy to take questions on individual infections. So here's some broad messages. Infections profoundly affect the natural history of cirrhosis. The epidemiology and bacteriology of infections are changing radically, partly due to the things we are doing, the medications and the antibiotic prophylaxis. From gram-negative, we're moving towards gram-positive. For infection, have a high index of suspicion. Be very flexible about antibiotic use, but use it very rapidly. Make sure you're using the appropriate antibiotics. You must talk to your ID team and work out a plan so that you can start antibiotics very quickly in these patients. Prevention of second infections, that is challenging in these patients because they've got the immune, it's what we call cirrhosis-associated immune deficiency. So the prevention of second infections is challenging. There is a move towards trying culture-independent approaches to diagnose infections, but right now they're still not easily available for patient care. Try and work strategies that reduce the burden of antibiotic resistance and fungal infections, and these are likely to improve outcomes. Additional messages here. Infection risk is because of bacterial translocation and impaired immunity. Once that happens, they are at high risk for mortality. Patients who get infected are at risk for reinfection and they get delisted from transplant. There's an increasing prevalence of MDR infections. Be very judicious about uses PPI, rifaximin, and antibiotic use, including for SBP prophylaxis. Very important, effective antibiotics within 1 hour in septic patients. Thank you. And I'm happy to take questions now.
Dr. Kamath, thank you so much for that wonderful talk. I think our audience learned a lot from this. This is a very important topic. The infection and cirrhosis particularly is such a broad topic, and you went through so lucidly, so comprehensively. I think our audience truly will appreciate all the invaluable insights that you had given today in your lecture. On behalf of United States, I would like to truly thank you for coming to our platform and enlightening us on this topic.